Imagine someone looking you right in the eye and telling you that a highly specific disease is just 100% fatal, like instantly fatal.
Right. No treatments, no interventions, just, no hope at all.
Exactly. And then, I don't know, decades later, you find out that the entire medical establishment was just, well, looking at it completely wrong for centuries.
Yeah, I mean, it sounds like this absolute failure of science, right? But that is actually the genuine history of one of the most common medical emergencies in the world. We were just fundamentally blind to it.
So today on the deep dive, we are looking at myocardial infarction, but specifically through a specialized clinical and nursing lens. We're taking our stack of sources, so, the pathology studies, the historical archives, the modern clinical guidelines, to really decode what an MI actually is at the cellular level.
Right. We really want to understand the biological mechanisms behind that famous phrase, time is muscle. And of course, dive into the whole high sensitivity troponin debate and explore the immediate emergency care protocols that, nurses and doctors use every day.
Okay, let's unpack this. Because for a clinical audience, we already know the basic anatomy. But the actual etymology of the word infarction, it actually carries this very specific, physical pathology that sets the stage for everything else, right?
It does, yeah. It's a beautifully grim Latin root, actually. Infarction comes from the word infarcere, which literally means to stuff.
To stuff,
Yeah,
like stuffing a turkey.
Basically, yeah, because when early pathologists opened up the chest on autopsy tables, they weren't just seeing, generalized wear and tear on the heart. They were seeing this very distinct, literally stuffed, wedge-shaped mass of dead, hardened tissue right in the ventricular wall.
Oh, wow. So it's something you could visibly, physically see.
Exactly. It's a highly physical endpoint. And it's really important to distinguish it from angina. With angina, reduced blood flow causes temporary ischemia, which is basically cellular oxygen starvation, but without permanent damage.
Right, they bounce back.
Yeah, exactly. But in infarction, that means the cells have undergone completely irreversible necrosis. They are dead.
And, well, because heart cells don't regenerate in any meaningful way, that dead zone just gets permanently replaced by non-contractile scar tissue, right? Like the heart's mechanical efficiency is just altered forever.
Right. It never fully recovers its original state.
But to understand how we manage an MI today, we have to figure out how doctors even realized this was, a survivable, treatable condition in a living person. Because for centuries, if you had sudden, crushing chest pain and died, what was the official diagnosis even called?
Historically, physicians just blamed it on apoplexy.
Apoplexy. That sounds so old-timey.
It really is. It was basically this medical catch-all term for suddenly dropping dead from some kind of cardiovascular or neurological collapse. They just didn't know. Later on, they started using the term angina pectoris, which was actually coined by William Heberden way back in 1768.
Okay, 1768. But he was just describing the pain, right?
Right.
Not the actual cause.
Exactly. Heberden was only describing the sensation. The prevailing medical dogma at the time was that if a coronary artery suddenly clotted off, the patient just died instantly. Full stop.
Which means, I guess, there was zero incentive to try and diagnose it in a clinic. Like, if coronary occlusion is completely synonymous with sudden death, you're only ever going to see it on an autopsy table.
That was the deadlock. You can't treat what you think is instantly fatal. But there is a massive historical twist here. The person who first broke that deadlock and actually diagnosed a coronary thrombosis in a living patient was Adam Hammer. He was an Austrian-American physician working in St. Louis.
Wait, really? When was this?
He made the clinical connection right at the bedside in 1878.
1878. But wait, I'm looking at our sources, and the physician who gets all the textbook credit is James B. Herrick. And he published his landmark paper in the Journal of the American Medical Association in 1912. That's like more than 30 years later.
Right, so here's the crazy part. Hammer published his 1878 report in German, and because of that language barrier, the English-speaking medical establishment just completely ignored it.
You kidding?
No, his discovery basically just vanished into the archives.
So this is like discovering the blueprint to save a burning house, but the fire department just ignores it because it wasn't written in English. That is infuriating. It just goes to show you how scientific firsts are usually about who had the social capital to get believed, not who actually made the discovery first.
What's fascinating here is that Herrick undeniably did the much harder sociological work. I mean, his 1912 paper, it was called Clinical Features of Sudden Obstruction of the Coronary Arteries. He actively argued that coronary occlusion was survivable.
He had to really fight for it.
Oh, absolutely. He correlated the clinical presentations of living patients with later autopsy findings to prove that the initial clot didn't kill you instantly. The damaged, healing heart muscle produced a clinical syndrome you could actually recognize.
Right, but I'm guessing the doctors of 1912 didn't just accept that immediately.
Oh, not at all. Being right wasn't enough. Herrick spent years just relentlessly arguing with a highly skeptical medical community to reframe MI from an autopsy curiosity to a living, actionable disease process.
And Herrick, proving that patients survive the initial clot. Well, it forces us to ask a pretty terrifying biological question. If they aren't dying instantly, what is the heart muscle actually doing during those first few hours after the blood stops flowing?
Well, the biological clock starts ticking the very second that fatty plaque ruptures and the thrombus, or clot, stops downstream blood flow. The heart muscle cells, the cardiomyocytes, are just uniquely vulnerable.
Because they need so much oxygen, right?
Exactly. They have virtually zero capacity for anaerobic metabolism, especially compared to your skeletal muscles. Since your heart never gets to rest, its cells are just packed with mitochondria that demand constant, uninterrupted oxygen for aerobic metabolism.
So when you cut that oxygen off, they don't just switch to a backup power system. They immediately start to suffocate. And our sources detail this concept called the wavefront phenomena, which was discovered by cardiac pathologist Robert Jennings in the 1970s.
Yes, Jennings's canine studies were groundbreaking for this.
Right, so when the artery blocks, the tissue doesn't die all at once. The cell death actually starts in the innermost layer of the heart muscle, the subendocardium, at roughly the 20-minute mark.
And the mechanics of why it starts there are fascinating. That innermost layer, it's under the highest physical pressure from the blood inside the ventricle, and it is the furthest away from the epicardial coronary arteries, which sit on the outside of the heart.
So it's basically the hardest zone to supply with blood, even on a good day.
Exactly. Once an occlusion happens, that inner layer collapses first. From there, the tissue death spreads outward through the muscle wall toward the exterior. It literally moves like a wave.
It makes me think of a slow-moving flood in a house. Like if you can stop the water when it's just in the basement, the foundation takes some damage, sure, but the house stays standing. But if you just sit on your hands for 3 to 6 hours, that flood reaches the roof, and the entire house is ruined.
That captures the clinical reality perfectly. By 3 to 6 hours of total blockage, that wave of necrosis extends through the entire thickness of the muscle wall. And that results in what we call a transmural infarction.
A full-thickness dead zone. And this is the biological foundation for that phrase, time is muscle. Every single minute dictates how far that wave of death travels. And to really prove how critical those minutes are, we have the ISIS-2 trial from 1988, right?
Oh, the ISIS-2 trial is a cornerstone of modern cardiology.
They took over 17,000 patients and found that simply giving a patient aspirin within 24 hours of a suspected MI reduced 5-week vascular mortality by 23%, just from aspirin.
Right, and then adding streptokinase, which was an early clot-dissolving drug, to that aspirin reduced mortality by roughly 42% compared to the placebo. I mean, it definitively proved that acting fast to intervene in that wavefront literally saves heart muscle.
And I really want to emphasize why saving that specific muscle is so vital to you listening, because it goes back to something we mentioned earlier, regeneration. If you damage your liver or scrape your skin, the cells divide and they heal. But you don't get new cardiomyocytes, do you?
No, you really don't. And Olaf Bergman's 2009 carbon-14 dating study quantified this beautifully. He proved that even in healthy young arts, only about 1% of muscle cells are replaced per year.
Wait, 1% a year? That is practically nothing.
It is nothing, and that minuscule replacement rate plummets even further as we age. So time is muscle isn't just a catchy slogan. It is a biological reality, because whatever you lose in those first few hours of the wavefront, you are losing for the rest of your life.
Which means the ultimate pressure is on the nurses and clinicians to diagnose the infarction as quickly as humanly possible. But if the cells are actively dying in a wave, how do we actually measure that cellular death in real time without, cutting the chest open?
We look for the leak.
The leak?
Yeah. As those cardiomyocytes suffocate and undergo necrosis, their cell membranes literally break down and rupture. All of their internal cellular machinery just spills into the surrounding tissue and eventually washes into the systemic bloodstream.
Ah, okay. And the primary piece of machinery they spill is cardiac troponin.
Exactly. Troponin is the protein complex that regulates the calcium-triggered interaction between actin and myosin filaments. It's basically the physical lock and key mechanism that allows the heart muscle to contract in the first place.
And you can detect that in the blood.
You can, because the specific troponin isotopes found in the heart are structurally distinct from the troponin in your skeletal muscles. So detecting them in the blood is a highly sensitive, highly specific indicator of cardiac cellular destruction.
So it's the ultimate biomarker. I know it totally replaced older enzymes like CKMB. But the kinetics of how it actually enters the blood are pretty tricky, aren't they?
They are. Troponin typically becomes detectable within 2 to 4 hours of the initial injury. It peaks around 12 to 48 hours, and it can linger in the blood for up to 14 days after a massive infarction.
And that time delay is exactly why serial nursing measurements are so critical. Because a single troponin draw tells you almost nothing useful in an acute setting, right?
Right, a single snapshot is useless. Clinicians are looking for the delta, the change over time. A troponin level that doubles in 2 hours tells a wildly different clinical story about an active, evolving injury than a stable, slightly elevated number does.
Troponin is so integral to modern cardiology that it actually forced the medical community to rewrite the rulebook entirely. The 2018 fourth universal definition of myocardial infarction explicitly shifted to a biomarker-driven diagnostic framework.
Yeah, that was a huge shift.
It requires evidence of myocardial injury, meaning an elevated troponin paired with clinical evidence of acute ischemia, like new ECG changes or severe anginal symptoms.
The diagnosis is now entirely mechanistic. We aren't just relying on a patient's subjective description of pain anymore. We are physically measuring the chemical debris of their dying heart cells.
But this introduces a massive clinical debate in emergency medicine right now regarding high-sensitivity troponin assays. Because these next-generation tests, they can detect troponin concentrations at incredibly microscopic levels, sometimes 10 to 100 times lower than the older generation.
Which is great for speed. It allows doctors to rule out an MI in just 1 hour.
Right. But the catch is that they are so sensitive they pick up microscopic leaks that have absolutely nothing to do with a plaque rupture.
Exactly. Severe kidney failure, sepsis, pulmonary embolism, or even the intense physiological strain of running a marathon can cause a tiny amount of troponin to leak into the blood.
So troponin is basically a highly sensitive smoke detector. It's great that it can detect a smoldering fire in the walls before you even smell smoke. But if it's so sensitive that it goes off just because someone is, like, boiling water or blowing out a candle in the dining room, which is essentially what a marathon runner's benign troponin leak is, aren't we risking rushing healthy people to the operating room?
This raises an important question, and it really requires clearing up a massive misconception in the field. An elevated troponin confirms myocardial injury, not a myocardial infarction diagnosis. You cannot look at a positive troponin in a vacuum.
It has to be married to that clinical evidence of oxygen starvation we talked about earlier.
That's the key. And it's why the universal definition splits MIs into different classifications. Type 1 MI is your classic pathology.
Huh.
A plaque ruptures, a thrombus forms, the artery blocks. You have to rush that patient to the cath lab to physically thread a wire into the heart and open the vessel.
Right, ideally meeting that 90-minute door-to-balloon metric.
Exactly. But type 2 MI is a completely different biological mechanism.
Right, because there's no clot.
Exactly. A type 2 MI is a supply and demand mismatch without any acute plaque rupture. Picture a patient with profound anemia or septic shock, or even a dangerously rapid tachycardic rhythm.
So their body suddenly demands vastly more oxygen than their previously narrowed but stable coronary arteries can deliver.
Precisely. The cardiomyocytes still starve. They still undergo necrosis. They still leak troponin into the blood.
So the lab results look completely identical, but the treatment protocol is the exact opposite. If you rush a type 2 patient to the cath lab, you aren't going to find a fresh clot to stent. You're just subjecting a highly unstable patient to surgical risks for literally no reason.
The intervention for a type 2 MI is to fix the underlying physiological trigger. You transfuse blood for the anemia, you give fluids and antibiotics for the sepsis, or you slow down the heart rate. The diagnostic framework has to be incredibly sharp here because the objective numbers can easily mislead you.
Which forces us to look at what happens when the patient's physical presentation also lies to the clinician. We have this culturally ingrained idea that a heart attack always involves a patient clutching their chest in agony, describing, an elephant sitting on their chest.
Oh, television loves that trope. But the reality is that silent or atypical presentations are dangerously common. We see this particularly in women, older adults, and individuals with long-standing diabetes.
Why diabetes specifically?
Well, for a diabetic patient, chronic hyperglycemia causes systemic neuropathy, and that nerve damage blunts the afferent pain fibers running from the heart up to the brain.
Oh, wow. So their nervous system just isn't transmitting the alarm bells at all. They might just present with profound fatigue or unexplained nausea or vague referred pain in their jaw or back.
Exactly. They can look relatively stable while that wavefront of cellular death is actively tearing through their ventricle.
That is terrifying. And then on the completely opposite end of the spectrum, you have the ultimate mimic, a condition that looks clinically identical to a massive heart attack but involves zero blocked arteries.
Yes, Takotsubo cardiomyopathy, or broken heart syndrome. It was first formally described by a Japanese cardiologist named Hikaru Sato in 1990.
And the pathophysiology of this one is just wild. It's triggered by an acute, overwhelming surge of emotional or physical stress, like the sudden death of a spouse, a terrifying car accident, or a catastrophic natural disaster. It just floods the central nervous system with catecholamines, primarily adrenaline.
And that massive surge of stress hormones is directly toxic to the myocardium. It completely overwhelms the beta receptors, particularly at the apex, which is the bottom of the left ventricle,
Yeah.
essentially paralyzing the muscle tissue.
So they show up looking like a classic heart attack.
Right. The patient presents with classic STEMI symptoms. They have crushing chest pain, massive ST elevation on their ECG, and a spike in their troponin levels.
But when you get them to the cath lab and shoot dye into their coronary arteries, the vessels are wide open. There's no plaque rupture.
Instead, the extreme stress has caused that paralyzed left ventricle to balloon outward. It takes on a highly distinct shape, with a narrow neck and a wide base.
Right, and Sato noticed it looked visually identical to a traditional Japanese octopus trap, which is known as a takotsubo.
Exactly. That extreme stress completely impaired the heart's mechanical ability to pump without a single blood clot being involved. It's a diagnostic minefield for clinicians.
So what does this all mean for the patient? I mean, let's say the diagnosis is straightforward for a second. It's a classic type 1 MI. You get them to the cath lab, you inflate the angioplasty balloon, and you clear the blockage. The blood is flowing again. I think most people, myself included, would assume the danger has passed and the patient is safe.
That is perhaps the most dangerous misconception in cardiology. The first few hours immediately after the arteries reopened actually carry the highest risk of sudden cardiac death.
Wait, I'm stuck here. If you just cleared the blockage and flooded the starving tissue with fresh oxygen, that should be the moment they are safest. Why is that the exact moment they are at the highest risk of dropping dead?
It comes down to a phenomenon called reperfusion injury and how it affects the heart's electrical wiring. See, while the artery was blocked, the starving cells switched to inefficient metabolic pathways, building up massive amounts of lactic acid and toxic waste products.
Okay, so there's a buildup of garbage in the cells.
Right. So when you suddenly restore blood flow, that rush of fresh oxygen hits all that damaged cellular machinery, generating a massive burst of oxygen-free radicals that actually cause further tissue damage.
So you're basically washing all of that concentrated acid, intracellular potassium, and toxic metabolic waste straight into the systemic circulation of the heart all at once.
Exactly. And that sudden chemical shift creates severe electrical irritability. The heart relies on incredibly precise ion gradients to coordinate its pumping. The tissue that died, bordering the tissue that was just rescued, becomes electrically chaotic.
And that leads to arrhythmias.
Yes. This reperfusion phase frequently triggers fatal arrhythmias, primarily ventricular fibrillation, where the heart just quivers uselessly instead of actually pumping blood.
So the doctors might have fixed the plumbing, but the electrical wiring is actively short-circuiting, which really highlights why the bedside nursing role is absolutely critical in the ICU, like continuous cardiac monitoring, managing the hemodynamic instability, and having a defibrillator instantly ready to shock the heart back into a normal rhythm. Those things are just as vital as the physical stent.
Absolutely. The intervention doesn't end in the cath lab. That continuous nursing vigilance is the literal barrier between a patient recovering and a patient suffering sudden cardiac death from a reperfusion arrhythmia.
To pull all of this complex pathology back to the big picture for you listening, cardiovascular disease is lethal, obviously, but the major takeaway from all of our sources is that it is uniquely actionable and largely preventable.
Oh, completely. Just look at the Interheart study from 2004.
Right, the one led by Salim Yusuf across 52 countries. It completely reframed how we view MI risk.
The Interheart findings were a total paradigm shift. They demonstrated that just 9 modifiable risk factors account for over 90% of the population. Attributable risk for a first myocardial infarction.
90%.
90%. We are talking about smoking, dyslipidemia, hypertension, diabetes, abdominal obesity, psychosocial stress, poor diet, lack of exercise, and alcohol consumption.
Which means 90% of the risk comes down to daily variables. It proved that a heart attack is not just this unavoidable genetic destiny for most people. It is heavily dictated by our environment and our choices. And it's incredible how public perception of this has evolved over time.
Oh, for sure.
Like when President Dwight Eisenhower had his massive heart attack in 1955, it was reported with such intense public candor that the U.S. stock market actually plummeted. But it also dragged the disease right out of the shadows. It proved to the public that an MI wasn't just this sudden private death sentence. It was a survivable disease process that really required public health awareness.
And the entire trajectory we've discussed today, from Herrick proving the initial clot was survivable, to mapping the wavefront of cellular death, to detecting those microscopic troponin leaks, is really a story of medicine learning how to visualize the invisible damage happening inside the chest and then intervening faster and faster.
Which brings up a final, somewhat unsettling thought I want to leave you with, pulled straight from the Framingham Heart Study data in our sources. We've established today that an infarction leaves a permanent, non-contractile scar. And we've detailed how stealthy the symptoms can be, especially if neuropathy blunts the pain.
Right, the silent MIs.
Exactly. The Framingham data show that a highly significant fraction of myocardial infarctions are only ever discovered retrospectively. A patient goes in for a routine pre-op ECG years later, and the doctor sees the definitive electrical Q waves of an old scar. The actual event was entirely silent and completely unrecognized by the patient when it happened.
They never even knew.
So, think back to the beginning of this deep dive. When doctors missed the diagnosis for centuries because they assumed a heart attack only looked one specific way, if the physical symptoms can be that completely invisible and the resulting tissue death is that permanent, could you, or someone in your family, have already survived a silent wavefront of cellular death without ever taking a single aspirin? And how would you even know?